Hi, everyone. Welcome back. I'm Sonika Garcia,
And I'm Brad Davidson, and this is Breaking the Code.
a podcast series addressing misconceptions related to the discipline of behavioral science. We hope to arm you, our listeners, with the tools you need to make sense of behavioral science and to help you apply it to your work as communication extraordinaires. Thanks, everyone. This is episode 19.
Wow.
And yeah, 19. We're almost at 20. I have to say, I think that after recording every episode and getting feedback and interacting with our listeners, now more than ever, I get really excited to brainstorm like the topic for the next session. And we have so many that we need to dig into because of like conversations we've had with our listeners and conversations that have evolved from like previous episodes. So I just want to say, like, I've been loving that.
Well, this is what's great about social science, right? Is the world's an endlessly fascinating place, and there's endlessly fascinating stuff going on in every corner of healthcare all the
Yes.
time,
Yep.
So
Yep.
I think we could do episode 2000 without breaking a sweat, although I think
I
we'd be very
know.
old
Yeah.
by that point.
Yep. I
But yeah,
feel
we're
the
running
same.
out of fingers and toes soon, so it's kind of
Yeah.
exciting.
Yep, yep. All right. So in today's episode, we are going to be digging into how culture and mostly culture, but also some other things like power dynamics and different categorizations of a person impact someone's communication and dialogue. And there's a lot to say on this topic. So today specifically, we wanted to explore language and communication a bit more. I think that's such a big part of behavioral science. And a lot of times we focus on how does someone's belief impact their behavior, their attitudes, their motivations. But we do know that language and communication impacts behavior as well. And so we wanted this episode to focus specifically on dialogue and communication. Because as communication professionals, every day we're hypothesizing about how people communicate or how people want to be communicated to, right? Because we're creating communication tools every day. But a big part of understanding that is understanding how different cultures and someone's lived experience because of their cultural background impacts the way that someone speaks and how someone wants to be spoken to. And because we work in healthcare, I think that this conversation is even more important because every day we're creating tools for doctors and patients. And I think that that really adds an extra layer of complexity to dialogue because think about it, as a doctor you're responsible for saving lives and making someone well again, and as a patient you're maybe dealing with the hardest phase of your life and the most trying time. And so communication in those two settings is even more challenging and has multiple layers to that. So we're going to be specifically talking about doctor patient dialogue in a little bit of a twist. Instead of just kind of diving into the topic as we usually do, we are going to shake things up throughout the episode. Brad is going to be sharing anecdotes from 3 doctor patient conversations. And then we'll have a conversation about that story and what he saw. And for those of you who don't know, or some of our newer listeners, Brad is a linguist and he spent many, many years in the healthcare setting, in the hospital setting, actually observing doctor patient dialogue. And so he has some great examples. So, Brad, I'm going to kick it over to you.
This is what you could call really like a true home game for me because, as Sanika says, this is not only what I studied, but what I ended up writing my dissertation on was the sort of situated nature of doctor patient dialogue. And situated nature, I'm putting big air quotes, that's sort of like fancy speak for just a lot of nested cultural contexts that show up. So you have a doctor who represents many years of study, many years of training, his or her own background, showing up in this tiny little room, the exam room, and a patient who represents an entire life, an entire worldview, an entire background. And they show up and they both have expectations for this visit. But what's fascinating about this clinical encounter, as they call it, is it has this institutional frame around it, meaning there's an you probably shouldn't talk too much about like how the Jets are going to do this year or something like that. Like there's a purpose for you being there. and it's to diagnose and treat illness, at least in the mind of the doctor. Now, in the mind of the patient, there might be a number of other goals. Get sign off for permission to leave work early to go, something like that, or get a prescription for something that you need that's not related to this particular visit. There's a lot of things that people are looking for. Social services. How do I connect with this or that? Like for many people, especially recent immigrants, the hospital is the closest they get to the institutional governing structure of the country, because they're not comfortable, say, going to the police sometimes if they're illegal. This was in California, so you have so many dynamics and so many different objectives of the two participants. And man, when there's three or four, it goes crazy, right? If the whole family's there. But I wanted to talk through these examples. We sort of went through them yesterday because I think they illustrate aspects of the clinical encounter that we often don't account for as marketing professionals when we're writing, say, discussion guides or choosing a lexicon or making suggestions as to how the dialogue could improve around a certain condition. So the first one I want to talk about is a doctor I observed in the mid 90s that I have to say I wasn't very personally fond of his style. He was, to orient him, this was in, you know, Northern California. I want to be as vague as possible. Northern California somewhere, public hospital, big public hospital, saw about 150,000 patients a year. And this guy would, do his clinic day. There was one day a week where you did the public clinic. And I would follow him sometimes and I would sit in on him. And I found him to be the most overbearing, vicious, just sort of like non interactive doctor I had observed in ages, ever really. And
Wow.
the ironic part was his patients loved him, like adored him. And it was because of the population he was treating. So his patient core was really a lot of migrant workers from Michoacan and Chiapas. So Mayan Indians, for the most part, ethnically Mayan, first language, Mayan speakers. Their Spanish was not great, some of them, and they absolutely expected a doctor to be institutionally and personally exactly the way Dr. Overbearing was. And I had to sort of check my own sort of beliefs about that and go, I had this a priori belief that a good doctor patient engagement was a back and forth between the patient and the doctor. Things were sorted out and everybody reached a sort of an alignment and agreement. I'm not so sure this doctor knew very much about any one of his patients at all. And I'm telling you, I interviewed the patients after these visits. They thought he was the best doctor in the world. And part of what was going on is, from their world, a tall, white, educated, institutionally powerful person is not someone that you should engage with. It was disrespectful to ask the doctor questions. I would ask them, would say, like, why did you ask him any questions? You clearly have a question for me. And they would say, well, because I'm going to ask the nurse on the way out. I'm not going to ask the doctor. And they wouldn't put it in these words, but they go, well, that's inappropriate. I don't want to challenge his authority. I'm grateful for his knowledge, and I'm grateful for his ability to help us get better or treat my
Mhm.
mom or whatever it was. And so I my own sort of prejudice, my own bias that like this is bad doctoring, I had to throw it out the window. Like for some patients, it's excellent doctoring. And so there's this idea that we have that like there's only one way to be a good doctor for patients. Some patients and some cultures don't want that. Now, that doesn't mean that every Mayan Indian immigrant who's in Northern California wants to be treated that way. So this is something we talk about a lot as well, that like knowing, as Andre said in the inclusive design one, you can't pretend that race doesn't exist. On the other hand, you don't want to be essentializing and say, well, because they're this, therefore they like that. What you do need to be aware of is this person not asking questions isn't necessarily a sign of passivity or disengagement from their own healthcare. They might not be asking questions of this doctor because they just don't think it's appropriate. You have to see who else they might be asking questions. That's vignette one of cultures really influencing the dynamic of the dialogue, which had I just looked at the transcript, I would have said this was a spectacular failure. 100% hit rate of satisfied patients. Just very interesting for me as a
Yeah.
not super experienced researcher.
There's a lot there that's very interesting. immediately my brain goes to like, well, they might not know any better because they haven't had a different experience in the healthcare setting, or like this is so much better than anything that they maybe have gotten in the past. So like they'll take anything and they don't know that they can have a voice and blah blah blah. Like obviously my mind goes to like a patient advocacy standpoint, but I think the key takeaway here is that we need to, as you're saying, like if we see a patient not asking questions or not being engaged, we can't just immediately jump to our own conclusions based on work that we've done or other research that we've done and thinking, oh, they feel silenced. They want to be empowered, but they don't have the resources. Like we can't automatically jump there, because when we do is we jump there and then we immediately create tools to help improve, the patient's self-efficacy and knowledge and all of that. However, they might not even be able to utilize those tools, or might not even want to, and that's okay. Whether or not we think, they should, and they should have a voice and they should feel like they should question their doctor, so we're going to help them do it. If they don't want to and they're comfortable and they're receiving the care that they feel happy with, I think that that's important information that we need to know and honor to some extent. Like that's what I'm taking away from that story.
Again, I think it's complicated. I think everything you just said, right? Maybe they're just their expectations are low, but I also think when we are faced with different cultural norms, to attribute to that then a lack of education or a lack of evolution is a trap, right?
Mhm.
We have to take at face value that these patients were very happy
Yeah.
with the care that they were receiving, and they felt that Dr. Overbearing was a
Mhm.
great doctor, a
Yeah.
knowledgeable, educated, thoughtful doctor who told them the answers that they wanted. And for that cohort, had he tried to engage them, it might have been distressing. Like, how come
Yeah.
this guy's not telling me what's wrong? Again,
Yeah.
I don't have the answer there. I do know that some of the guides that I see us write about patient doctor dialogue seem to be written for people who are heavily empowered in an
Yes.
institutional
Yeah.
setting. And that
Yeah.
is not everyone. And if
Yeah.
the first step is to empower everyone in an institutional setting and then we can fix it, we'll never fix it. Right. So we have to meet people where they are. That is actually the mantra of client service, right? Is meet them where they are. And if this is a cohort that for whatever reason prefers a certain doctor patient dynamic, and they found their way to him. There was
Mhm.
choice involved here. Like, this was a preferred doctor. They had
Mhm.
some choice as to who saw them. Not that the other doctors were bad, they just thought this guy was great. that
Yeah.
one that one every time that we go, like, the real need here is engaged patients or activated patients. Yes, and there are patients who are perfectly happy not being activated. Now, the important part here is you have to have a mechanism by which they can ask their questions. And they had one. They were more comfortable post visit talking to the nurse. Now, that would
Mhm.
frustrate the clinic because then the nurse would ferry a question to the doctor, and the doctor was like, I was just in there with them. But that was how they were
Mhm.
comfortable sort of getting stuff done. And so it begs the question again, as always, like, whose norms are we normalizing? And
Yeah. Yeah. That's actually interesting, because then, of course, maybe it's creating inefficiencies, but then the solution there shouldn't be necessarily, okay, well, how do we make them more comfortable to talk to the doctor? It's how can we like help make it a more efficient process to help them continue to talk to the nurse? Like how, if that's what they're comfortable with, as you say, meeting them where they are, the solution is not to like change them completely or try to do that, but rather just improve the process that they're currently doing, if that's
yeah,
where their comfort is.
I think there's two takeaways, right? One is make sure that you understand what people actually want. Like, sort of quote, improve the process assumes that we know what the best optimal format for that is, and we don't. Not for everyone. People have a choice in this stuff. And the other is we should probably ask them. We're busy sort of figuring out like what we think is the right thing to do and what direction to go in. But this is where the inclusive design part comes in. Might as well
Yep.
ask the people who are going to be served by this sort of intervention to see what they want. So again, I think I'm not trying to throw my hands up and go, therefore, there's nothing you can do. I'm saying this was a really profound moment for me where I started rethinking what I thought was ideal in the doctor patient interaction. There were tons of flaws in the interaction as I've described it, including being afraid of the institution that is serving you is not a positive thing, right? Be
Yeah.
if you're there on like sketchy legal basis, which by the way, large swaths of the California economy require routine sort of a circuit of immigration where people come up from places like Michoacan and do a
Hmm.
lot of labor and then go back down, and both economies benefit according to people. And so like you have to live in the real world. Like this is not a group that's going to feel super empowered in an institutional setting where, to be fair, people might start asking for their ID, you know? So anyway, that's one. And I think the takeaway is not everything is always as obvious as we think it is in terms of solutions. Sometimes we might even be uncomfortable with solutions. We might feel that they're patronizing or continue colonial patterns of interaction, or many other discussions I had with people over years about this. But the reality is, at the end of the day, if that patient feels like they were well served, we have to take that at face value.
Okay. Love that. I'm curious about the next story.
So the next one I think is just more funny about power dynamics. So one of the things that people always talk about in my world when we look at doctor-patient interactions is these are power asymmetries, right? The doctor has literally embodies the power of the institution. He or she is the final say on prescription and stuff like that. And a patient is the opposite. They are the client of this, but they are dependent on the doctor. If the doctor decides that no, you aren't in so much pain that you need X, then you don't get X. And there's it's not between equals. It's not a marriage of equals, as they say, right? And so a lot of times we don't fully account for that, but this one is more funny. One of the doctors that I was following for my dissertation was heavily pregnant. Well, started pregnant, ended up, you know how these things go. It progresses, they grow, and so by the end of my research, she was about 2 weeks away from delivering. And first of all, I thought she was one of the most amazing doctors I've ever been around. She was kind, she was thoughtful. She somehow managed to make like a 10 to 12 minute interaction feel intimate and slow, like all the time in the world. She just had so many good habits that I've learned from and tried to remember. But, she was really struggling towards the end to like move around comfortably in a very small office. And one day she was finishing up with someone and she went, "Okay, we're done." And then she did this thing that I've never forgotten and I've never seen anything like it since. She said to the patient, "Can you help me out of my chair?" And you're a mom, in the last couple of weeks, like, or I don't know when, but like it's starting to get a little hard to get yourself up out of the chair. But she reached her hand out, and I could just see on the patient's face, like, utter confusion. And then he was thrilled to help her, and he, gave her a hand up and all that sort of stuff. But it was such a stark reversal
Hmm.
of that power dynamic, and she was so comfortable with it. And this patient for a second wasn't, and then was. And it was such a
Yeah.
glimmer of thing. And I was like, wow, what an inversion, and what a statement to her as a doctor that she didn't need the institutional authority, that mantle to sort of feel powerful and strong. She was just like, hey man, I can't get out of my chair. And how rare that was, and how infrequently I see that power dynamic inverted in any real way. It was pretty striking, actually.
To me, the takeaway there is we always say doctors are humans too, but it's doctors are patients too, right? Like that's what I get from
Right.
that story. That doctor in that moment switched over to being a quote unquote patient, right? You know, when you're pregnant, you go to your OB, you are a patient. And so I love that.
I hate using this word, but it was charming. It was like there
Yeah,
was a
yeah.
disarming charm to her. It was not a strategic move as far as I could tell. No, again,
Hmm.
you never know what's going on in someone's mind. She was just in the
Hmm.
most natural way, like, okay, I've just served you. Can you give me a hand and help me up? And I also
Yeah.
think, pregnant women, again, just observationally, pregnant women in general, people react differently to. It's almost like, oh, thank you on behalf of the species for continuing us. Like people are like attracted to touching pregnant women. I'm sure I heard about it all the time from those, like, if one more person touches me, I'm going to like chop their hand off, right? But people are constantly wanting to sort of be part of that process, which I find fascinating. But when you're a doctor and you're supposed to be this powerful, really intellectual creature, and you become this needing help physical creature, it did call into relief that we often forget how human they are, and that they're
Yeah.
real, like teachers, they're behind a desk, or cops, they're behind a badge. But behind that badge is a person just like you and me. And when you invert those power dynamics, interesting things happen. So
Mhm.
that was one, again, I always sort of think about that when we talk about either that power dynamics or shared decision. This really, I guess, informs shared decision making. Like shared decision making, big air quotes, is very different in a power dynamic that is very clearly one up, one down than
Yeah.
say between equals in a marriage or something like that.
Yeah. Yeah. Well, I think that's the takeaway that he humanizes the doctor, and we need to remember that. So, love that story.
Yeah, the last one is my favorite in some ways because it really gets to the heart of, again, I don't mean to like keep name checking Andre, but Andre brought out like a couple episodes ago, like it's racist to think that there's no such thing as race. Like people's experiences and who they are informed, guided by, shaped in part by things
Mhm.
like race, religion, height, weight, all that stuff. But one way of making sure that you don't lose yourself in a sea of stereotyping, oh, well, this is a Mayan Indian patient, therefore they want X, is to make sure that you're actually checking that. Right. So started as almost like not a default setting, but you start with the idea that maybe this person is in this sort of mindset, but then you confirm it. And so this doctor, we'll call him Dr. J, he went on to, by the way, to have some very important positions at different academic institutions in California. So I'm gonna sort of stay away from sort of giving any information about him. But he was at this clinic as well. It was a really interesting place, and he told me, Brad, there's one question I love to ask at the beginning of every interview because it tells me just about everything I need to know. And it goes like this: he would say, "What do you think it is?" That's it. What do you think it is? And he said the answer would give me three really important data points. The first one would be I would listen for the vocabulary, the type of language they're using, because that tells me their level of health literacy. So if they say, well, I have a boo boo on my knee versus I have a hematoma deep in the, what, I'm making stuff up, right? But like
Yeah.
you can hear in people's responses their
Mhm.
level of education, their level of health literacy. That's something that I think that's passion for you, right? Is how do we determine health literacy? So if I ask you, what do you think it is? And I listen to how you give me an answer, now I can adjust, I can align my, as they say in linguistics, I can attune my language to your level, to what you
Yeah.
want. And then two, he said, is it tells me how engaged they want to be. Because some patients will go, I don't know, doc, you tell me, you're the doctor. And you go, perfect. Now I know exactly what this patient wants. They want me to
Yeah.
tell them what it is. Versus someone who goes like, well, I spent 3 weeks online before I came here, and here's my binder. And that's someone who wants to do a lot of research, who wants to be really engaged in their own care. So, right. So, what do you think it is? Get you two things right off the bat: their level of health literacy, or at least a beginning of an understanding of that, and their level of, not even their level, what their desired role in this whole interaction is, right?
Mhm.
I said, in the third one, which is sort of more clinical than anything, I said, sometimes they're right. Sometimes they tell me things that I wouldn't have asked or I wouldn't have thought to ask, or it turns out there's a deep-seated fear of colon cancer because it runs in the family, and I don't know that because I don't have a full chart on them, and I would never have asked about that. So then you go, okay, I got a good family history out of that. So he said, so a lot of times the information they provide is useful, although it's probably not what I'm going to base my entire diagnosis on. It's useful in ways that I wouldn't have imagined. So here's a guy who super educated, super powerful. Doctor, we used to joke like Doctor Mighty Famous Big Shot, MFB, Mighty Famous Big Shot. I mean, he became one of those, and but
Yeah.
very humble, very smart, and his first move was to figure out what you wanted and who you were by asking a question.
Mhm.
And that to me is such a huge learning point for any of these things that we do. You look at the discussion guides that we create, the doctor patient dialogue, and it starts with how you doing. But that's just a rote formulaic sort of opening, like how you doing, and I want to hear fine. Let's jump right into your psoriasis kind of thing. What do you think a good solution would be, or not what do you think it is? Because if it's already diagnosed, I mean, he was not running, but he was running a practice at a clinic. where you didn't necessarily get the same people over and over. So you were kind of going from scratch a lot. But let's say you have an established relationship with somebody. So okay, you might already know their level of literacy, you might already know their level of engagement. You still haven't really given them a chance to give their opinion about what's going on. In fact, doctors spend a lot of time shutting that down. And we
Mhm.
write discussion guides about shutting that down. And we
Mhm.
need to be a lot more porous. Now, that gets into training, but I think the idea that it's all on the doctor to come in the right way. And if they just use the right words right up front, everything will go smoothly. No, it's an interaction between two situated humans who have differing goals, and for that 10 to 15 to 20 minutes are mutually engaged in a collaborative endeavor to diagnose and create a treatment plan for whatever's ailing the patient. If that doesn't include the patient in a meaningful way, it's somewhat wasted. And I know that's completely contradictory to doctor overbearing, but I still have my own belief that doctor overbearing, even though the dynamic was exactly what everyone wanted, I have a feeling things were missed because there wasn't the back and forth. And so,
Mhm.
I do think there is a better way of engaging with patients, and it involves hearing what they have to say. I could be
Yeah.
wrong, but that's totally my belief structure. So,
Yeah.
again, anecdote one, give patients what they want. People know what they want. They're not children. We can't tell them that they're wrong. But, vignette three, I do think an interactive meeting is far more satisfactory and much more likely to diagnose what's truly bothering the patient and help them solve it. So those are my three.
Yeah.
Yeah. Anyway,
Awesome. Yeah, I think the last example is a doctor doing from a communication standpoint and like a behavioral strategy standpoint the work that we exactly want them to do. And I love to hear that, there are doctors out there that are asking those kind of questions because if I'm being honest, I don't know that I've ever had an interaction like that where I'm being asked, not only like, well, what do you think it is, but like, how do you want this to go? How do you want this relationship to go? And being okay with that answer and doctoring accordingly, I think is that's great. Thank you, Brad. Those are I know you have so many more stories and I'm so curious to hear them. But I think those three were really great examples and very different to kind of show the different parts of doctor patient dialogue communication and the importance of understanding the human behind the patient behind the doctor to really get the best results from like a communication standpoint. I think that one of the takeaways that you started touching on towards the end is that when we develop communication tools, whether it's for doctors to talk to patients, whether it's for reps to talk to doctors, patients to talk to their support system, because we create those sorts of tools as well. I think usability research is critical. So, like, we can create all the tools, we can try to say, like, this is what you should say. But unless someone knows, one, how to use the tool, whether that tool is created appropriately for this person of this background, I think we sort of miss that. And I think from a doctor's standpoint, at least, it would be very easy for us to, from a co-creation standpoint, create these tools with them, hear from the people who the tools are being created for on what they think, what would work best based on their experience, and then have them try it out, right? Like, take this, try
yeah,
it
that's a
out,
big one. Yeah.
yeah, tell us how it went so we can, because I think right now it's just us hypothesizing and yeah, based on research and all of that, but we don't get that feedback, which I think is really important.
I agree with everything you said. I think one more takeaway is think about that last question, right? What do you think it is? That's just 6 words. And it gave them an entire window into their world. I think we overwrite these things. I think there's something called clinical pearls, which are just little nuggets that you can adopt immediately into your clinical practice. And that one's a clinical pearl.
Yeah.
That one is, I'm not asking you to memorize a dialogue. I'm asking you to remember 6 words in a question to
Yeah.
start the interaction. And it can, I guess the one thing that all of these things had in common was the way that these doctors interacted with these patients really defined the nature of the information exchange. Even if the middle doctor, the pregnant doctor, hadn't done what she had done, She was very good at being on patients' levels. They adore I think people would have walked through fire for her, to be honest. I mean, when I would interview her patients afterwards, they would just be effusive. Now, all of these doctors were working in the same public clinic. They were providing the same service, and all of their patients liked them. So I think the other takeaway is it's a wide tent. You know,
Mhm.
not everybody has to be exactly the same, but that there's, there's an expression, not every teacher is a good teacher for every student. I think it's
Mhm.
really, really, really true. Not every doctor is a good doctor for every patient. We should recognize that. It's not a crime to say that some people get along with other people better. Now, you should be able to do a decent job for patients that you don't understand, but you will do a better job for patients whom you understand and they understand you. It'd be foolish to say otherwise, I think.
Yeah, I agree. I think the last point that I like to touch on, I know that we made this point before in other episodes with segmentation, and I think that all medical communication is cross-cultural, like, especially in the
Yes.
healthcare field. There is constantly brown individuals are not paired up with brown doctors. That's just not how it works, right? So we have a doctor from a certain cultural background, a patient from another, and that's constantly the communication that's going on. I think we need to keep that more front and center in our communications and our strategy, because that is more than your training, more than your practice setting, more than your age, your gender, like where you come from, the customs that were embedded in your programming from such a young age. That is what comes out in occupations for doctors and patients and how they interact. So I think we need to keep that more front and center. We check off all the other boxes, but I think culture and background is something that is very important and we need to think about more.
Very well said. Quick
Well,
to end on.
yeah, and I think we'll get a little bit more into that discussion with culture and language. I want to do a follow-up episode. This was more about like communication and dialogue and specifically in the healthcare setting. But Brad, with your experience, I would just be so interested in having a conversation about how language itself, like words and the things that people say, how that impacts perception and belief and behavior. Because I think we say it all the time, language impacts behavior, but like I wanna know how. I wanna talk more about that. So
Oh,
that's
for
to
sure.
come. Yeah.
Yeah, yeah, yeah.
Um, all right. Thank you, everyone. Another great episode. Thank you, Brad. And until next time, I'm Sonika Garcia.
And I'm Brad Davidson, and this is Breaking the Code.
Bye.
Bye, everyone.
Breaking the Code is a podcast by Havas Health and U's Medical Anthropology Department. Created and produced by Brad Davidson and Sonika Garcia. Content editing done by Catherine Rossi. Post-production audio editing done by Gabriel Allen Cummings. And inspiration by all of you. Thanks for listening and your continued support. If you enjoy these episodes, we would love to hear from you. Please leave a rating and subscribe. Until next time.